Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're decoding the critical patterns the brain shows us when it's under serious pressure. These are the high-yield, absolutely must-know neuroscience that tell you exactly what's going wrong and, just as importantly, where. Let's jump right in. So let's start with the most basic problem of all. Your brain lives inside a rigid, bony box, the skull. There's just no room to expand. So when pressure starts to build up, say from swelling or bleeding, the brain has literally nowhere to go. It can't push out, so it starts to shift and squeeze inwards and downwards. And these predictable shifts, well, they're the key to everything we're about to talk about. And this whole process is called herniation. Now, the crucial thing to get is that the brain doesn't just squish around randomly. No, it's forced along and through these tough membranes inside the skull, the falx and the tentorium. And right there, that's where the diagnostic magic happens. The specific direction of that shift, plus whatever vital structure gets compressed along the way, that directly equals the exact symptoms you're going to see in your patient. So, time to put on our detective hats. We're going to decode the 4 major herniation syndromes, basically by following the breadcrumb trail of clues that each one leaves behind. First up, the one you'll see on every exam, the absolute classic, and you can lock it in your brain with this one simple phrase: blown pupil first. This is the dead giveaway for uncal herniation. So, what's physically happening here? Well, the part that moves is the uncus. That's the innermost bit of the temporal lobe. As it gets shoved downward, it smashes right into 2 critical things: cranial nerve 3, which, controls your pupil, and the cerebral peduncle, which is basically a superhighway for motor signals. And that compression leads directly to this textbook clinical picture. That squashed cranial nerve 3, that gives you an ipsilateral, meaning same-sided, blown pupil. It's huge, and it won't react to light. The muscles that move the eye are paralyzed, so the eye itself just kind of drifts down and out. You also get ptosis, a droopy eyelid. And at the same time, the squeezed motor tract causes contralateral, opposite-sided weakness. But wait, here is a classic high-yield exam trap you absolutely have to know. It's called the Kernahan phenomenon. Sometimes the brain shifts so hard that it actually shoves the opposite side of the brainstem against the skull. And when that happens, you compress the motor pathways on the other side, which paradoxically causes weakness on the same side as the blown pupil. It's a huge clinical curveball designed to trick you. Okay, moving on to our next pattern, the one-line anchor for this one. Midline shift leads to leg weakness. We're talking about cingulate herniation. In this case, the cingulate gyrus, which is part of the frontal lobe, gets pushed sideways, right under that falx cerebri, the membrane separating the 2 halves of the brain. The key structure it compresses this time isn't a nerve, it's a blood vessel, the anterior cerebral artery, or ACA for short. So why does that matter? Well, the ACA is the artery that supplies blood to the part of the brain that controls your leg. So if you pinch it off, you starve that area of oxygen, and you get this very specific contralateral leg predominant weakness. This one isn't about pupils early on. It's all about that leg weakness. If you see a CT scan and that midline is shifted way over, this is what you should be thinking about. Our third pattern is easily the most immediately life-threatening. The one-liner here is as simple and scary as it gets: stops breathing. This is cerebellar tonsillar herniation. What's happening here is that pressure builds up in the back of the head, and it forces the cerebellar tonsils down through the foramen magnum, that big hole at the base of your skull. And what's sitting right there waiting to be crushed? The medulla. The part of your brainstem that controls breathing and consciousness, the absolute basics. The clinical picture is just as devastating as you'd imagine. When you compress the medulla, you get sudden respiratory arrest. The patient just stops breathing. This is followed almost instantly by coma, and if it's not fixed in seconds, death. It is a catastrophic final common pathway kind of event. And that brings us to our final and arguably most devastating herniation pattern. The anchor is simple: straight down equals deadly. This is central herniation. So instead of shifting to the side, here the entire upper brainstem gets forced straight down, like a piston. As it's jammed downwards, it stretches and tears these tiny, delicate little blood vessels called the paramedian branches of the basilar artery. These are the arteries that keep the brainstem alive. And this causes a terrifying, progressive downward spiral. Loss of consciousness, followed by abnormal posturing as the brainstem fails. And that tearing of those little arteries, that causes what we call durate hemorrhages, bleeding directly into the brainstem. This is pretty much a terminal event. It's almost always fatal. Okay, wow. We've just covered the big structural brain shifts. But now, let's pivot. Let's forget about the massive movements for a second and zoom in on the signals themselves. The key here isn't about what's shifting, it's just about thinking, where is the damage? And that brings us to the classic neurological showdown, upper motor neuron versus lower motor neuron lesions. The question is really simple. Is the problem up in the central command, the brain or spinal cord, or is it down in the wire itself, the nerve going out to the muscle? And this slide lays it out perfectly. Now, they both cause weakness, sure, but that's where the similarities end. For an upper motor neuron, or UMN lesion, just think everything goes up. You get increased tone, spasticity, you get increased super brisk reflexes, and you get a positive Babinski sign. For a lower motor neuron, or LMN lesion, everything goes down. Decreased floppy tone, decreased or totally absent reflexes, and then you see the muscles start to waste away, atrophy, and you see fasciculations, those little twitches under the skin. So why the huge difference? Well, with UMN signs, the damage is central. You've essentially cut the brake lines from the brain. Without those calming inhibitory signals coming from above, the local spinal reflexes are left completely unchecked. They just run wild, and that gives you the spasticity and hyperreflexia. But with LMN signs, the damage is in the nerve itself, after it's already left the spinal cord. The muscle has lost its power cable, its direct connection to the grid. Without that signal, it goes limp and floppy. It shrinks because it's not being used, that's the atrophy. And it gets irritable, which causes those spontaneous little twitches, the fasciculation. All right, we have covered a ton of ground. So let's lock it all in with a super quick, rapid recall summary. These are the one-liners you just have to have in your back pocket for exams and for the wards. Let's just run through them rapid fire. 1. See a blown pupil? Think uncal herniation. 2. Leg weakness with a midline shift? That's your subfalcine. 3. A sudden coma with brainstem bleeding? That's central herniation. 4. Apnea, suddenly stopping breathing? Tonsillar herniation. 5. A positive Babinski sign? That screams upper motor neuron. And 6. See those little muscle twitches, fasciculations? That points straight to a lower motor neuron problem. So look, these aren't just a bunch of random facts for a test. They are distinct, readable patterns that a human body will show you in a moment of absolute crisis. You've just learned the language. You have the decoder ring. So the only question left is, which one of these patterns are you going to see next?